Hello, everybody. Thank you so much for joining us this morning to talk about the Health and Care Act. We recognise that we asked you last minute and we really appreciate you taking the time out of your busy schedules to join us. We're going to try and keep things brief today, a brief briefing. We're joined by Stephen Savory, who is a GP who will be able to tell us a bit more about his experiences and thoughts on the front line. We've tried to set out the situation as we perceive it. So there's just three quick things to mention before we get going. We're all going to mute ourselves when we're not the ones talking. There's going to be a Q&A at the end for myself and Stephen. And so if you've got questions as we go along, just pop them into the box, the chat box, and we'll be writing them down. And in fact, that covers all three of my points. So let's get going. So the presentation today is called the Health and Care Act, What's Going On? Hannah, could you move on to the next slide, please? So this is our agenda. Like I say, my name's Julia. I'm the Chief Executive of EveryDoctor. We're an organisation who represent UK doctors, and we run a much wider network of NHS supporters. We're going to be joined by Dr. Stephen Savory this morning, and there'll be a Q&A at the end, and then we'll wrap up. It might be slightly quicker than this today because I have to say the presentation is quite short owing to the lack of information available currently. Hannah, could you move on to the next slide, please? Okay, so I thought we'd start just with an overview of what the Health and Care Act is. I'm certain that you guys will be well versed in it, but just a recap. The Health and Care Act is going to roll out in England on the 1st of July 2022. It's been described as enacting the most significant health legislation in a decade into law. And we run an online forum of about 25,000 doctors. And so we're talking every day with them about what they're seeing in their workplaces. And the majority of doctors that we're hearing from have not been given any information about the local plans for this major NHS restructuring rollout. And so we're very concerned about that. Hannah, could you move on to the next slide, please? Thank you. Okay, so the Health and Care Act is going to change things in a number of ways. It's going to cause the dissolution of the CCGs, which are currently within NHS England. And it's going to change the structure of healthcare in England so that patches of populations will now be covered by what are called integrated care systems, which I'll explain in a little bit more detail. There's going to be 42 of these areas within England. The overarching aim, as described by the government, is that they feel it will enable greater integration of health and social care services, supporting productivity and sustainability of services, and helping the NHS to support social and economic development. It's very unclear what this means in practical terms, and there isn't a lot of detail available. What is clear is that it's going to be heavily dependent on the ways that local areas enact the detail of this bill. There's quite a lot of flexibility, and the concern from ourselves currently is that because there is such flexibility in how they choose to use this act, and we're 5 weeks away from the act being implemented, a lot of people are throwing their hands in the air right now and are really unclear about who's responsible for what and what's going to go on, you know, in the coming months. And that's a concern for patients, it's a concern for staff, it's a concern really for managers as well in how things are going to be run. Hannah, could you move on to the next slide, please? Thank you. So I'm just going to briefly highlight some of the concerns that a lot of people have had since this health and care bill has first been posed. They're not just our concerns, these have come from campaigners, from politicians, journalists have written about them. So you'll be aware of this already, I'm sure. Any NHS reorganisation is a major task because it's an enormously complicated service. And changing things, reorganising things takes up an enormous amount of energy and resource, both at a local level and at a national level. We're currently in a really dreadful situation in terms of healthcare. partly owing to the COVID pandemic, but also we were in a terrible position before the COVID pandemic. Currently in England, we have NHS waiting lists of 6.4 million patients, which is the longest they have ever been. We also have 110,000, perhaps more, NHS staff posts currently vacant. And this particular bill did not contain any provision for making a plan to tackle these things in a specific way. In fact, the only information I've been able to see about how this is going to get tackled is a sort of punitive blaming of NHS staff. It's not a helpful way that the government are currently engaging with NHS staff about this very significant issue. And this is something that could have been tackled by the Health and Care Bill and wasn't, unfortunately. You'll obviously know that there's a provision within this bill for something called the social care cap. It's been lauded as a way of making things easier for a lot of people and bringing social care costs down, particularly for vulnerable people or people in later life. However, it has been criticised from lots of people because it's going to disproportionately impact low earners, and that's a problem with this bill. The bill itself is going to give more powers for the Health Secretary, and I'll come on to discuss that in a little bit more detail. And our concern as NHS carers, NHS campaigners, is that there's a lot of NHS services at the moment which are being run by non-NHS providers. Some of them are private companies and some of them are other services. However, if you start giving NHS services up for other people to come in and start running services, it disrupts the infrastructure within the NHS and it can disrupt care relationships. And all of this adds to the sort of bureaucracy, confusion, potential for problems at a time when you're making a major restructuring plan. So that's a potential complication as well. There's a huge concern from our doctor members that there is inadequate representation of clinical expertise and patient representation within the layers of these integrated care systems. Now, I'll show you a graphic in a minute that kind of sets out how these structures are going to interact. In order to run healthcare well, we really need to be utilising the expertise at a local level in terms of patient population and what patients need. And there's a real concern that this Health and Care Act is not going to maximise the input from those people. Okay, so this is a very complicated graphic and I'm not going to attempt to describe it in detail, but we will be sending this around to everyone so you can have a closer look. But just as an overview, this is a graphic which shows how these integrated care systems are going to be working. I don't know how much you guys know about this already. So they're comprised of two parts. There's the integrated care boards, which are on the left-hand side, and these are the 42 boards that will be around England, and these boards will be making decisions about local healthcare. We definitely need more clinical representation on these boards, but I'll allow Stephen to give a little bit more detail about why that's a concern. And as you see, they allocate NHS budget and they commission services locally. They'll be producing the 5-year system plan for health services. And then on the right-hand side, we've got the integrated care partnerships. Now, this is tying into this idea that the NHS needs to work more closely with social care services. So these ICPs will have representatives from local authorities, from the Integrated Care Board, which is on the left-hand side, the NHS bit, from Healthwatch and other partners. And these integrated care partnerships will have a role with planning to meet wider health, public health and social care needs. And both of these groups are going to be managed by, or sort of NHS England will be governing it all, and the CQC, the Care Quality Commission, will be assessing how they're doing. You've probably got lots of questions looking at this graphic. I certainly do. NHS structures are incredibly complicated, always have been, and every single time something gets restructured, it takes staff years actually to figure out the detail. So I suppose we're grappling with yet another system, which is going to involve a lot of change, and the relationships between different services and structures in the NHS is delicate and complicated in order to look after patients safely. So you can see that, you know, given the fact that most of the doctors we're speaking to haven't been provided with any information about these new structures, it's a bit of a concern. Could you come on to the next slide, please, Hannah? So this is just a graphic showing the poll that we've run in our forum. We just popped this up, left it up for a couple of days. And as it says, I'm a doctor working in England, and with regard to the Health and Care Act's imminent implementation, and people just ticked one of the boxes, as you can see, of the sort of 360-ish votes we had, 351 of them are doctors who have said, I have been provided with no information about local plans. So that's not brilliant, given that it's 24th of May today, and it's going to all get implemented on the 1st of July. So there's a sort of 5.5 week window now. Could you move on to the next slide, please, Hannah? So we sent out a survey to our doctor community to find out a little bit more about people's concerns locally, and we've had lots of quotes back. We're just detailed a few of them here, so I'll just read these out. So the first person has said CCGs or evolving ICSs have gone through a pretense of consultation. So clearly, locally, there's been some effort at involving clinicians in sort of what's going to happen, but it doesn't sound like this person's convinced it's been a a valid consultation. The second person says they've got a concern that there'll be marginalisation of a generation of clinical leaders best placed to advocate for their patients and communities. This is going to disenfranchise primary care where 90% of patient contacts take place. They're going to be replacing competitive tendering, a bad idea. That's what's currently going on, with an absence of scrutiny for contracting services outside the NHS, which is a worse idea. Now, this is tying into this idea that this act is meant to make it easier to start contracts. And the concern from campaigners has been, although privatisation isn't specifically mentioned within the bill, that less scrutiny and bureaucracy will take place when an outside provider wants to run an NHS service. And reading between the lines, this looks like it's going to mean that people can come in with less scrutiny, run NHS services, and from past history, we know that that can lead to problems and services not being run well, or contracts coming to an end quickly, or patient safety not being of a high priority for the people running the service. And so clinicians have got a real concern about a reduction in the level of scrutiny when these contracts are awarded. And then the third point here, it says very few people not directly working in a role affected by the bill know it's happening, much less what the implications might be. Even people who know about it have only a very high level idea of how things will be structured. So that's a problem, because what happens locally is you need to have meetings about this sort of thing and delve into the detail and work it all out. And it doesn't sound like that's happening at the moment. Brilliant. Hannah, could you go on to the next slide, please? Okay, just going to carry on with more of these. So somebody has said there'll be less continuity of care. A very dismantled and broken system that does not communicate and interoperate between various services is most likely going to evolve. So I suppose what sometimes gets lost in the media when we talk about the NHS is that it's actually a series of services, and they all need to work well with each other. There's a lot of phone calls, letters, interaction, and if any of those interactions falls down, patients lose out. So when things get changed in a major restructure like this, those relationships are really key, and there's a concern that they won't be prioritised. The second bit here says the final stage of the privatisation and corporatisation of the NHS. This will result in a continuing deterioration in working conditions and pay for the majority of NHS workers, as well as a significant worsening of morbidity and mortality for the general public. Now, like I say, there's nothing specifically in the bill that talks about privatisation. I guess this is a fear and a concern, and this is one that is widely held amongst our community, I have to say. It might sound like fear mongering, but we are deeply concerned about the sort of destruction of the infrastructure within the NHS and the infiltration of private services. And the last thing on here says minimal primary care representation on some boards on a background of negativity towards GPs, conversations at the highest level about salarying GPs to trusts, leading to fears of the partnership model being destabilised further. The unintended consequences of this could be loss of some of the most experienced GPs within a few years. So this is referring to the fact that recently there has been a lot of media negativity towards GPs. GPs were instructed at the beginning of the pandemic that they should move to a telephone consultation model wherever they could. GPs did this, and then there was backlash in the media at a time when GPs honestly have never been busier. They were trying to juggle face-to-face appointments where necessary and telephone consultations, and being criticised in the national media. And this has led to destructions and deteriorations of doctor-patient relationships, which have been very, very damaging. And there's a concern, I think a legitimate concern, that as this major restructure happens, the voice of primary care physicians who do manage the bulk of medical care within the NHS is becoming quietened, and it's reducing the autonomy of these incredibly important clinicians within the NHS. Okay, could we have the next slide, please, Hannah? Fantastic. Well, I think I have spoken enough. So I'm going to hand over now to Dr. Stephen Savory, who is an EveryDoctor member and he's a GP in Lincolnshire, to tell you about what he's worried about. Stephen, over to you.
Good morning, everybody. Thanks for inviting me, Julia, to talk about something which, to be honest, I don't know a great deal about, as do a lot of EveryDoctor members. I've been a GP partner in Lincolnshire for about 27 years. I train medical students, I train future general practitioners. In the past, I've been actively involved in clinical commissioning as a clinical lead for our CCG. More recently, I've become chair of the Lincolnshire Local Medical Committee, which I'm horrified to find makes me something of a senior statesman. It also makes me the repository of our organisational knowledge. What I'm going to say over the next 5 minutes or so is very much a local view. It's a personal view as well. It's not necessarily the opinions of the organisations whose logos are splattered behind me. In terms of covering for my ignorance, I thought I'd start for a couple of minutes by talking about the clinical commissioning groups, which ICSs will replace in only a few weeks' time. They started off with very laudable aspirations. This was meant to be about bottom-up, clinically led commissioning. GP membership organisations, as Julia's already said, primary care, ourselves, community nursing, pharmacy, other parties on the high street. We are often the first point of contact for patients with the NHS and with care organisations. We provide 90% of those encounters. A lot of us are independent. We're embedded in our communities. We feel our patients' pain, and when things aren't working for them, we're often the ones who are there to sort things out. Critics were worried that in CCGs, clinicians, GPs would become the fall guys for rationing and that we lacked management skills. In practice, I think the potential of CCGs was never achieved, but the fears were never fully realised. CCG constitutions give clinicians relatively little flexibility to lead decision making. They have to be approved by NHS England. PCT managers are the Primary Care Trust and NHS England managers of old, and were perhaps more responsive to national asks than local needs. A lot of the management work for CCGs has been outsourced to large provider commissioning support units, which are private. I'm going to come back to them in a few minutes. Those decisions about outsourcing have not been GP decisions. So meaningful change over the last few years has been hampered by inadequate staffing, inadequate funding, and a management whose head is too easily turned to national and often political wants rather than local needs. Those of us in commissioning who have been vociferous for patient safety, quality of care and organisational governance have found that there are fewer protections for us than there are for people, clinicians who are providing immediate care to patients in hospitals in terms of whistleblowing policy. So, moving forward to the Health and Care Act, which comes into place in 6 weeks' time, and the introduction of integrated care systems. Again, potentially at face value, this is an attractive proposition for health and care to work closer together for the benefit of individuals, for the benefit of communities. I would echo what EveryDoctor members have said in our poll. There has been a complete failure locally to reach out to frontline practitioners here and to grab hearts and minds. Efforts to engage with provider organisations, be they GPs, hospital trusts, community trusts, have been limited. And in the meetings I've been in, I've seen clinical representation falling away week by week. The structures and governance of our local integrated care system is as clear as mud. Julia's slide was one of the most clear I've seen. Locally, I've seen a multiplicity of schematics, talk about integrated care partnerships, integrated care systems, integrated care board, strategic board, clinical and care directorate, clinical and care academy. I could go on and on and on. Primary care spent a lot of time in recent weeks trying to ensure appropriate representation as an integrated care board. Currently, legislation says we have a minimum of 1 seat at that table, and any additional seats for primary care, be that GP, pharmacy, optometry, dentistry, that has to be granted by NHS England. In terms of GP providers' voice within the organisation in Lincolnshire, there's talk about setting up a primary care liaison group. The composition is perhaps being firmed up, but the governance and where it sits in the organisation is still totally unclear. It's unlikely that representatives, frontline clinicians are going to be determining ICS policy. Perhaps even more concerningly is the lack of clarity about the operational status of the organisation from 1st of July. At the moment, the CCG's got 4 GPs providing the equivalent of 6 days a week input into operational matters, decision making. They don't know what's going to be happening to them in 6 weeks' time. Moving on, the integrated care partnership with local authorities. Again, a lack of clarity, understanding, transparency about what's happening on the ground here in Lincolnshire. For me, looking to close health inequalities and improve the standard of care, this is a far bigger thing than just health and care services. These things depend on tackling poverty, educational opportunity, housing, employment, infrastructure. These are all big deals here in rural Lincolnshire, and I think the focus on health and care alone is going to hamper us enormously. For health and care to work together, we need to have bottom-up collaboration, not top-down diktats. The system has got to value and create time for local providers from health and care to meet, to talk, to understand our different professional roles, to build trust, understanding and solve our mutual problems for the benefit of patients, for clients and for ourselves. And in a system where we have routine demand overload and underfunding, the fear is that individual professionals and organisations remain in the relative safety of their silos. Julia's touched upon the big picture risks with integrated care systems. The Act appears to remove NHS responsibility for providing hospital services, replacing it with, and I'm quoting here in inverted commas, a requirement to arrange them to such an extent as it considers necessary to meet reasonable requirements. Again, there's a complete lack of clarity there. Julia's touched on contracting. We are now moving into a system where the ICS will be able to contract with providers with contracts for unlimited sums without competitive tender. Now that's a double-edged sword. It was originally spun as protecting NHS services and protecting patients against fragmentation of care. Often a patient with one or more illness will now be attending 3, 4 more providers to deliver their care, and there's the risk of them falling down the cracks in the pavement. We now have the risk here of contracting without advertisement and without proper scrutiny. I think I have a very real fear in Lincolnshire and beyond that providers, be they hospital providers or GP providers, will fail, and that new private providers will step into the gap there. Failing GP providers, their practices, their patients risk being vertically integrated into other provider organisations, community trusts, hospital trusts, who may have little experience of providing primary care services. There is a real threat here that your registered GP, as an independent advocate and coordinator of your care, is going to become a wage slave of a multinational corporation whose primary concern is their shareholders. Those potential private providers are currently contracted to provide the commissioning support that I talked about at the beginning of this. They're currently crunching big data, and that my concern and other members' concern is that that data may be used in the future to cherry pick which services, which bits of services that they want to provide, and that we end up sliding towards a two-tier system of healthcare, similar to what we see in the States, with an NHS service which is a bare minimum safety net, and then an insurance-based model for those who can afford to pay. In summary, what do I ask of my Member of Parliament and of our Members of Parliament? I fear that we have a diminished voice as clinicians in the new integrated care system. We as advocates for patients' care have few protections when we stand up and shout about quality and safety. And we request that our Members of Parliament are there for their ear and support to help us protect your constituents, and that we can be confident in your advocacy as we sail into uncharted and very dangerous waters. Thanks for listening.
Thank you, Stephen. That was brilliant. Okay, it's pretty heavy. And I would understand if there's a level of kind of confusion about the detail here. As Stephen and I have tried to, I suppose, explain, we're also quite confused, and we're worried about that, because if things aren't spelled out in a lot of detail to clinicians on the front line, as it's being referred to, it can lead to real problems for patients. This goes beyond sort of money and management stuff. This is a patient safety concern. We're very worried. We don't feel that the system has been tested thoroughly, and who knows what's going to happen in the coming months. But could we go on to the next slide, Hannah, and maybe we'll just talk about, yeah. So we would be very keen to work together with any parliamentarian who would be able to flag up to the government that NHS frontline staff need to be provided with more detail about implementation plans as a matter of urgency. So if you feel able to work on this in any capacity, please do get in touch with us. We would love to speak to you one-on-one, correspond, help with a letter, whatever would be helpful to you. Thank you so much. We've created an accompanying briefing document, and like I said, it's got that same graphic that we briefly touched on earlier in the presentation, because it might help you to understand the situation a little bit better. We'd be delighted to circulate that to anyone who you felt would like to see it. We'll send it out, I think, Hannah, won't we, to everyone who's present today. And we're going to move on now to the Q&A session. So the last I checked, there were no questions in the chat box. Let me have a little look. There's nothing in there at the moment. Does anybody want to pop anything in there? I'll just go quiet for a minute and see. Okay, there's nothing in there at the moment. I'm just going to talk over just in case anyone's typing. So if anybody does think of a question after we finish this meeting, please send it through to campaigns@everydoctor.org.uk and we'll be delighted to get back to you with any information you need. I'm just going to leave it for one more minute in case anybody's just writing now. No, doesn't look like it. Okay, well, this is a first, I think, that we've had no questions. But anyway, thank you so much for attending today. We really, really appreciate it. And please do get in touch if we can provide you with any further information or work with you to highlight this important issue. And not just now, but as the Act comes into place, I'm sure there will be problems and we will probably be calling upon you to help us raise attention about those.